Okay, hi, this is Karen Oaks. I am presenting my draft presentation for Nursing 5318 Advanced Pathophysiology. This is a Module 4 draft presentation. Here I have Erica. I am preceptor for Erica, who is a brand new NICU nurse. And actually what we're going to do today is expand information that I gave Erica a couple weeks ago on fetal circulation, which Erica and I have already kind of gone over that part again. What we're actually going to talk about is what happens when fetal circulation actually becomes a disease process. I kind of remember I talked to Erica years ago where when I first started, actually this disease process was called PFC, which is persistent fetal circulation, which kind of gave you an idea of, of what the process was at the time. Well, we have evolved a little bit, and so now we call it PPHN, or persistent pulmonary hypertension of a newborn. I do have a 8-point PowerPoint. I'll kind of turn it around a little bit here so you can see. I could have just flipped the camera around, huh? But anyway, we are going to go over this PowerPoint here in detail. I did have Erica complete. We actually worked together on a pre-assessment exam that we went over together successfully. We did talk about fetal circulation and the umbilical vein and its purpose, the umbilical arteries and its purpose, the three main shunts in the fetal circulation, which we talked about, our ductus venosus,
the foramen ovale, and the ductus arteriosus.
Perfect. Okay, and we also did talk about pressures within the two main components. Actually, Erica understands that the baby gets nutrients and oxygen from the placenta. The pressure, systemic pressure is low.
High.
Systemic pressure.
Systemic is low.
Low. Pulmonary, or the pressure in the lungs, is very high. Okay, that's like a basic understanding of what goes on in fetal circulation. So, as far as the objectives go, at the conclusion of our short presentation, and it's a very condensed presentation, Erica will be able to recall and discuss full understanding of fetal circulation, which we have already accomplished that goal. Compare and contrast fetal and neonatal blood flow, which we can kind of talk about that again because we did talk about that already. And as far as our actual disease process, there are certain maternal risk factors that we're going to talk about, how we diagnose PPHN, and then of course how we manage it as nurses. So one thing we are going to look at as far as risk factors for these babies, to kind of get ourselves a heads up on what to expect a baby that could be potentially develop PPHN. The mother has a fever, prolonged ruptured membranes. What else do you think? Meconium, and especially if it's meconium stained amniotic fluid, or if the mother is positive for Group B strep. Also, we talked about fetal intolerance of labor. If the baby doesn't have a good strip or indicates fetal distress, and again, a baby that may have a low APGAR scores. Okay. Once we get the baby into the unit, because we did anticipate that this would probably happen, we're going to put the baby on a warmer. We're going to keep the baby, maintain the baby's, what do we call it? Neutral thermal environment. In a neutral thermal environment is intended to keep the baby warm, to decrease metabolic and or oxygen expenditures and usage in a baby that's already stressed. So we want to keep a baby warm. we'll get the baby connected to a heart and respiratory monitor as well as a pulse oximeter. We monitor the baby's vital signs: temperature, pulse, respirations, blood pressures, pulse oximetry readings, oxygen saturation readings. We'll also monitor blood gas on this baby, blood sugars, an overall assessment, which includes perfusion and systemic blood pressures, of course. I want to make sure all of that is within a normal range there. We're also going to do what? What did I tell you about the handling of the baby? What do we do with that, as we call it?
Decrease stimulation.
Right. Try to keep a nice, quiet environment. We only touch the baby when we have to. About every 4 hours, a minimal stimulation and touch on the baby. Whatever we have to do to keep the baby calm and minimize oxygen utilization for this baby. At some point in time, the doctors, of course, they do order the pulse oximetry. We do pre and post ductal. We put a pulse oximeter probe on the
Right upper extremity.
And the other one,
On either one of the
lower extremities, to measure pre and post ductal oxygen saturations of the blood flow before it reaches the ductus arteriosus and then afterwards. The other way, the most important way actually to diagnose PPHN versus congenital heart disease, is through echocardiogram. So the doctor would certainly order that for the baby in order to ensure the diagnosis, make sure we're not treating a cyanotic heart disease as opposed to pulmonary hypertension in the lungs, or pulmonary hypertension. Let's see, what else do we have here? Do you have any questions for me at all? No? Do you have a full understanding? Okay, so we do have a pre and post test. I also should let Erica know. I did give her a copy of the PowerPoint. There are references there. I also have copies of every article that's included in the presentation for her to read, and here to answer questions for her, as well as the textbook that we kind of collaborate on together. So I'm hoping that the presentation, although condensed but to the point, Erica seems to have a good grasp of the concepts, and hopefully my goals have been accomplished. Thank you. Bye-bye.